mind and tell you about the exciting things that this NAPS consortium has been doing. In case if you don't know, that's unlikely, but in case if you don't know, NAPS stands for North American Prodromal Synucleinopathy, RBD Consortium. I think it's a mouthful. That's why we call it NAPS Consortium, to make it easier. Just to make most of our time, we're gonna get going and moving, and it is my great pleasure to introduce the co-host for today's webinar, Dr. Alon Avidan, who will also be next speaker and present the first topic for the day. Alon?
Good morning, everyone. My name is Alon Avidan. Like Dr. Videnovic, I'm a neurologist in sleep medicine and also a co-leader of the REOCORE, which is really designed to enhance recruitment, education, and outreach on behalf of the NAPS Consortium. One of my interests is really to further clinician and patient education. And as such, I think that RBDs is no stranger to one of the host of sleep disorders for which we as clinicians often struggle to educate our colleagues, oftentimes on disorders that they may not appreciate, and in so doing, improve the ability of patients to get appropriate and timely clinical care. Now, I've prepared a very short presentation on the topic of education and recruitment, and really providing a highlight of where the opportunities are as it relates to REM sleep behavior disorder. And for that, I'd like Adrian Rivera, our UCLA coordinator, to share a video that I recorded last night. So go ahead, Adrian, and share that video if you could.
One moment.
And Adrian, as you're prepared, why don't I go ahead and share it myself? So here we go. Promote that. Let me go ahead and stop share for 1 second. I'm going to share again. Hello, everyone. I'm Alon Avidan. I'm a neurologist and sleep physician at UCLA, and I'm going to be covering the appreciation of patient needs and expectations when it comes to REM sleep behavior disorder. I like to use this cartoon to highlight the disconnect between what clinicians hear and what they interpret from patients. Patients may present with a very aggressive dream enactment, which is often misinterpreted as anxiety and abnormal dreaming. Patients may receive the correct treatment, but for the wrong diagnosis, and that often leads to prolongation of the time in which patients may experience injuries, and prevents and delays the appropriate diagnosis of REM sleep behavior disorder. This anecdote of the blind man and the elephant is very appropriate to how, depending on what portion, what anatomy of the elephant the clinician is able to assess, they will come up with quite different diagnoses, ranging from epilepsy to Parkinson's to PTSD to sleep terrors and nightmares. The cultural variations in how one experiences or interprets abnormal dreaming is also partly to play in that certain cultures may experience and interpret different elements of dreaming quite differently, and in some cultures the nightmare episode, the abnormal hallucination, may not come to clinical attention very quickly. One of my patients, one of my very first patients at UCLA was a very, very nice gentleman who came in with a set of handcuffs and a seatbelt to help prevent him from acting out his dreams.
He felt so awful.
You can appreciate
that
from this
he
description.
made a seatbelt that went around the bed. He restrained his wrist. He literally hogtied himself at night.
This is how John used to go to sleep. Wrists and feet restrained, his body tied down.
The dangerous thing is I was getting out of bed, maybe attacking my wife, and to realize that I had no control over it, like Dr. Jekyll and Mr. Hyde.
And this gentleman really presented with quite an elaborate history of dream enactment and was initially told that this were just fits and spells and nightmares and sleep terrors, but he really struggled to receive the right diagnosis until he experienced a pretty significant injury. So the iceberg effect in that what is RBD, what is truly RBD and what it means often gets missed. Spells, RBD may get labeled as spells, sleep terrors, abnormal dreaming, and the delay in diagnosis often leads to stigma, lower quality of life, depression, safety issues, certainly, and patients often struggle with marital and relationship difficulties when the events are not fully understood, and of course, depression and isolation. Part of the delay in diagnosis is that when patients initially present with REM sleep behavior disorder, that is really the key time to intervene with potential neuroprotective agents when they do become available. And missing this diagnosis certainly can delay in the appropriate management and potential delay in progression and final conversion. I like to use this effect of the dam that the late Dr. William Dement, the father of sleep medicine, used, in that there is quite an accumulating sleep knowledge where there is a barrier often and to the very need of sleep education by clinicians, and this barrier often is related to inappropriate sleep education in medical schools, residency programs, and really we as sleep physicians also like to think of this dam as preventing patients, particularly those with RBD, from receiving appropriate diagnosis, management, and potentially also appropriate therapies to prevent and modify the course of their disease. And our job really is to break the dam and by providing better education, better physician and patient education to help everyone receive the appropriate diagnosis and evaluation in a timely manner. The educational barrier really is what our committee is responsible for. The education committee is really has this task of providing resources. The remedy is the REM sleep behavior disorder education delivery platform, which is designed to promote and educate physicians and patients using our NAPS portal as a vehicle to promote that. And the various components of educational stakeholders include physicians, primary physicians, as well as patients who can be effective liaisons in promoting and educating physicians who take care of them. And part of the Remedy website is really to provide those resources effectively in a way that really targets the various stakeholders effectively with appropriate, well-calibrated educational activities. I'd like to highlight one of them in that is an educational program that we recently provided to really allow for patient and physician education, but primarily focusing on physician education, primary physician education in particular. And here is the RioCore Education Committee for everyone's knowledge. And this presentation is really geared towards family physicians in knowing when to appropriately diagnose patients with REM sleep behavior disorder, not necessarily make a diagnosis or manage the patients, but knowing when to raise the red flag that the patient may have REM sleep behavior disorder. And we use a patient experience of a patient who suffered an injury and came in to their primary care physician with complaints that they're acting out and having fighting type dreaming. The patient, the observer are being, we use the quotation specifically, that the patient has experiences as if he is extra strong when they're sleeping, and they experience this potential injuries during the night. And the case will be highlighted with a video, but really we provided primary physicians with a differential diagnosis of dream enactment behavior, which is not really specific for RBD, but we also highlighted the diagnosis and the definition of parasomnias as undesirable behaviors or experiences from sleep-wake transition, providing an anecdote to when patients really need to be evaluated for REM sleep behavior disorder based on the notion that they have dream enactment, and also providing some information on when during the night REM sleep behavior disorder is likely to manifest. We highlighted the very basic principles for diagnosis, which requires a sleep study, and oftentimes primary physicians may not know that the patient needs a sleep study for diagnosis, but may order it nonetheless to evaluate and see if the patient has sleep apnea. But we wanted to send some important information that RBDs is not rare, it's common, 1 to 2% of the population, and it may be a sign of a potential neurodegenerative disease down the road. This relationship between RBD and potential phenoconversion to a neurodegenerative disease is really critical, so physicians will recognize that this is beyond nightmares. This is more than nightmares. This is more than sleep terrors. This is a specific parasomnia that occurs during REM sleep in which the muscle tone is abnormally elevated. They need to send the patient for sleep evaluation by a sleep physician who will then confirm the diagnosis and provide the appropriate management. We wanted to remind folks that there is quite a spectrum from mild to more moderate and vigorous dream enactment behaviors. We wanted to also remind folks that this was RBD was initially written about by James Parkinson's when he demonstrated a patient who was likely having RBD in the initial description in 1817. We'll include some anecdotes about potential risks of injuries and the spectrum of potential injuries, and the single most important question, which is, does the patient act out their dreams? And this is the bed partner questionnaire as part of the Mayo Sleep questionnaire, and reminding folks about pharmacotherapy as well as safety interventions, but also reminding folks that because there are two phenotypes of RBD, the isolated and the secondary or symptomatic RBD, there is a potential for phenoconversion from patients who may have isolated to symptomatic RBD, and really this is where we provide additional information about the phenoconversion rates for both patients and physicians who need to be aware that this is a disorder that has as a potential risk, that's a potential sign that the patient may go on to develop a neurodegenerative condition. We wanted to highlight why physicians should recognize RBD. It's not just a simple parasomnia. This is a parasomnia that has a really critical sign that the patient may go on to develop a neurodegenerative condition. And our basis of really providing this presentation is to remind folks that they should there are educational resources available through the American Academy of Sleep Medicine. The NAPS website will also include more and more patient videos, as well as videos for by experts in the field on what is RBD, what are we doing in the NAPS Consortium, the connection between RBD and brain health, how is RBD diagnosed, how is it managed, and also, of course, we have the YouTube channel, but we also have social media channels that provide additional information and resources about RBD. And the YouTube channel that was launched last year already has an ample collection of videos on the various topics of RBD. They're not very long, usually about, say, 5 to 10 minutes in duration, as well as recording from our previous webinars. And you can see the link right here, and we'll post this at the conclusion of the webinar so everyone can gain access to our YouTube channel. And here it is again. We'll highlight the various websites with the addresses at the conclusion of our webinar. And with that, I'd like to thank everyone, and we'll turn it back to the moderator. Thank you. All right, folks, thank you so much for listening to our first initial topic on the educational resources. Now it is my pleasure to turn the presentation back to my colleague, Dr. Alex Videnovic.
Thank you very much, Alon. Great presentation. I would like to let our participants know that you are welcome to submit your questions using a Q&A function of the Zoom, which is at the bottom of your screen. We will be addressing your questions during the Q&A session, and we really welcome you to submit some questions. We have received some in advance, and we really appreciate you being engaged with us. Now, my job today is to speak about a topic of biomarkers and the recent discoveries in the field of biomarkers, and you've probably heard a lot about it, and biomarker is a topic that is frequently being discussed these days, and this is really what the next 15-20 minutes we will focus on. You probably heard this word biomarker many times, but here is one of the definitions that is used for this term. Biomarker, which is really short for biological marker, is a measure, objective measure, that can capture what is really happening in a biological system, whether that be our whole organism or specific organ, or even change that is happening on a cellular level. So that is really what the biomarker is. There are many different types of biomarkers. And according to one of the classifications, you have here listed 7 different biomarkers. And I think it is really useful to gain some basic understanding what these different biomarkers represent. So I'm going to briefly go through these examples so that it gives you a good idea and that you start gaining knowledge about what these biomarkers, what information these biomarkers can provide. So let's start and let's go briefly over the list of these biomarkers. The first type of biomarker is a risk biomarker or a susceptibility biomarker. What would be a good example? Well, if individuals have certain type of mutations in these 2 genes, BRCA genes 1 and 2, certain type of mutations carry this increased risk of developing breast and ovarian cancers. So these mutations are really biomarkers of risk of developing this particular disease. The second type of a biomarker is a diagnostic biomarker. The example that I put here on the slide for you is a C-reactive protein. This is really a test, a blood test that we can run And this test indicates, is there a strong inflammatory response, inflammation in our organism? That's why we consider it a diagnostic biomarker. It is a diagnostic for inflammatory condition that may be happening. Then the third type, a prognostic biomarker. And I put here this level of protein, this protein Ki67. We understand that the levels of these proteins can be indicative of how aggressive certain tumors can be, and therefore can be indicative of worse outcome. So these prognostic biomarkers are able to tell us about the outcome, give us a prognosis on a certain medical condition. The fourth group of biomarkers is so-called monitoring biomarkers. Hemoglobin A1C is a well-known indicator that is a biomarker of monitoring diabetes. This is a blood test, and we all know hemoglobin A1C is above certain value, that trajectory of diabetes in that particular patient is not all that favorable, as opposed if it's below that value, which indicates good control of diabetes as a medical condition. Then the next group of biomarkers are so-called predictive biomarkers. And here we have this another protein here that I bring, and this is HER2 protein. And measuring these proteins, we can really predict what is going to be the response to certain treatment in for breast cancer. So very important, right? So that we can say, well, this level of protein is X amount, and therefore we believe that if we treat the patient with that drug, with the Y drug, right, the drug, that the treatment response can be really very good. Then we have pharmacodynamic or response biomarkers. Blood pressure is a great example of that. We're all familiar with measuring blood pressure, right? Well, if we study certain medications, or even if we are treated with certain antidepressants, measuring the blood pressure will give us a great idea how responsive we are to these medications that we are taking to blood pressure. Therefore, we call these response biomarkers, and fancy word is pharmacodynamic biomarker. And finally, there are safety biomarkers. And for example, liver function tests, which are blood tests, are good markers that are used to assess health of a liver, right? Many medications can affect liver in a negative way. And therefore, if we run these simple blood tests, we can monitor safety of a certain treatment and intervention for an organ, in this case, liver. So you see biomarkers, or these biological markers, can serve very, very different purposes. And you can certainly, from these examples, I hope, really easily conclude how important is to have these biomarkers that can tell us about the risk of developing disease, tell us about the response to medication, whether we can predict that this drug is good for us or not, tell us about how our disease is progressing, or whether certain treatments are safe or effective to be used. So this is just a brief introduction in the concept of biomarkers. You've heard probably, and many of you are likely participating in our NAPS research project, which is at the core of the NAPS Consortium. And I am happy to share with you that we collect many different biomarkers within the NAPS study. We collect many clinical biomarkers. These are all of those tests of motor function and cognitive performance and smell and blood pressure oscillations that we do. We, as you know, expose you to several imaging studies, and these are imaging biomarkers of the disease. You undergo a sleep study if you are participants in the NAPS project, and that study itself has many different neurophysiological markers of the disease. We also study genetic makeup to trying to understand which genes may be associated with REM sleep behavior disorder and the related disorder. And finally, what will be the emphasis of the rest of this talk, we are also collecting biofluid, because biofluids such as blood and the brain or spinal fluid are really very valuable resources where we can study and research and examine many different markers of the disease that can be very informative. And many of these biomarkers that are listed on this slide, types of biomarkers, belong and can be utilized as one or many of those different subtypes of biomarkers that I have discussed at the beginning of the talk. Now, we're going to move forward, and I'm going to introduce this concept of this protein alpha-synuclein. I am pretty sure that many of you have heard about this protein, alpha-synuclein. And here on this cartoon, on the left side of the slide, you see the structure of the protein, right? This is a 3D rendering of this protein, which we called synuclein. This protein is very important for our living. It is really very necessary for normal development of the organism, of the human body, and for the normal functioning of the body. And it is really very richly present and distributed in various nervous tissues, in our brain and spinal cord, nervous tissues, right? It is important to point that this protein, however, when it's a normal protein, it's a soluble protein, which means that it really does not precipitate in our nerve tissues. In Parkinson's disease and other diseases where there is accumulation of synuclein, and that's why we call them synucleinopathies, there is really accumulation of this alpha-synuclein, of this protein, which becomes insoluble, right? And then that previously normally soluble protein starts to aggregate, starts to accumulate in the brain cells, and forms these inclusions that we called Lewy bodies. And pathological accumulation of synuclein in these so-called Lewy bodies is a hallmark of these diseases such as Parkinson's disease, Lewy body dementia, and multiple systems atrophy, which are all quite associated with REM sleep behavior disorder, as you very well know. And here are the cartoons that illustrates these concepts that I told you so far. This synuclein protein under normal or physiological state is either bound for the cell envelope, or it exists in so-called free unfolded form within the cell or in between the cells. However, in pathological states that lead to formation of these Lewy body, there is a formation of conglomerates of these unfolded protein that then create these fibrils that become insoluble, and therefore protein nerve cells that is illustrated here cannot clear them. They deposit themselves in this nerve cell and create these structures so-called Lewy bodies. And here you have an example of a brain tissue slices where you can appreciate one neuron here that forms in the upper left panel, that forms dopamine with these clusters of Lewy bodies that are in the cell body of that neuron. Eventually that neuron will die. When enough of these neurons die, there are manifestations of the disease, such a decline in cognition, or problems with blood pressure regulation and urinary function, or tremors and stiffness, such as Parkinson's disease symptoms. So first we talked about biomarkers, then I talked to you which biomarkers we study. in Parkinson, in the NAPS project. Then I introduced this concept of synuclein and pathological synuclein that accumulates in the brains of patients with these disorders. And now I would like to tell you about this exciting assay, which is called alpha-synuclein seed amplification assay. Abbreviation here is SSA assay. This is a new technique that has been relatively recently developed, which allows us to detect that pathological protein synuclein in various biofluids or tissues, right? And this is really a huge breakthrough, because now we are able, through this technology, to detect presence of this pathological synuclein, which is the hallmark of the disease, in individuals, and therefore can differentiate patients who may have this pathological protein from those who do not have it. So one of the initial and very exciting projects, and this is really taken from the research paper, so bear with me here a little bit. I would like to report to you what is the power that this assay brings to our community, patient communities, research communities, etc. Let's take a look at this left part of the slide. The heading said CSF. That stands for cerebrospinal fluid. And here on the very left graph, you have a three group of patients where we have, not we, but the colleagues who reported this in the Nature, very prestigious scientific journal, have looked at the three group of patients. Healthy controls who don't have any disease, that's HC, patients with multiple systems atrophy, MSA, and patients with Parkinson's disease PD. And each of these dots here, either black, blue, or red, are representative of a single patient. And you can see clear separation and presence of these pathological proteins in patients with multiple systems atrophy and Parkinson's disease, as opposed to healthy controls, where the amount of this pathological protein pretty much stays at zero. You also see here a very clear separation between the results of this SSA assay in patients with Parkinson's disease and patients with multiple systems atrophy. And I'm not going to go into details here, but I'm just going to tell you that this separation here that you see between the blue dots and red dots indicates that the type of that pathological synuclein and the structure of that protein is a little bit different or a lot different between patients who have Parkinson's disease and those that have multiple systems atrophy. I am not going to talk about any of these other graphs. If you are interested, we can post and share this publication on our website. But here is just the power of an assay that can now really indicate the presence of this pathological protein, pathological synuclein, in the biofluid, specifically spinal fluid of patients with Parkinson's disease and multiple systems atrophy, in contrast to healthy control participants whose brain and spinal fluid will not have this protein. And this is a story about the Parkinson's disease, but this story is now permeating the field of REM sleep behavior disorder as well. And here is one of the papers that came out soon after this original report that looked at Parkinson's patients and other patients with neurodegenerative disease. And let's look at this paper. This is the application of a similar SAA assay, in this case, in patients with REM sleep behavior disorder. All of these patients in this study underwent spinal tap and got analyzed their biofluid for this pathological protein. And what investigators have then looked, they looked what is the risk of developing neurodegenerative disease in those patients with REM sleep behavior disorder over time. And that time you see here on this horizontal axis, which says time from lumbar puncture. So these patients were followed 2, 4, 6, 8, 10 years after the lumbar puncture, where they analyzed the spinal fluid for that pathological protein. And what home take message here is that individuals who go on to develop neurodegenerative disease and who have been initially positive for alpha-synuclein, and those are individuals who have this red line here. These are individuals represented in the red line. And you see that as the time goes back, that this line becomes steeper, goes down. And that means that more and more individuals in this group positive for synuclein is at a higher risk to develop a neurodegenerative disease, either Parkinson's or dementia with Lewy body, as opposed to those individuals that are represented in a blue line on the top, where you can see that those individuals, and these are individuals who didn't have that synuclein detected in their SAA assay at the beginning when the spinal tap is done, and you do see that those individuals who do not have that protein is at a much substantially lower risk, at the lower risk of developing this neurodegenerative condition. So how about SAA assays and our NAPS sample, our NAPS study? You know that we encourage our participants in the NAPS to participate and undergo spinal tap. And I'm happy to tell you that we do have a decent number of patients who committed to this spinal tap who are parts of NAPS Consortium. Not many as we would wish though, and that we are working with the several laboratories as well as the company Embryon on analysis of these samples that are collected through NAPS project. And we are trying to address potential challenges that may exist within these SAA assays. And this is really that assays may be quite variable between the different labs. And there are a lot of other supply chain challenges, and scaling this to the big scale, it's also a bit of a challenging. So that is why we are really working very hard to try to understand and develop assays that are going to be really very accurate in other samples. Wouldn't it be wonderful if we can do that in plasma, in blood? There are some assays that are already working in skin, but there are so many other biofluids that we can focus on and try to enhance the development of this particular assay for this pathological protein in these samples as well. As of now, unfortunately, the spinal fluid remains our best bet in terms of sensitivity and specificity, how accurate and precise we can be in deciding what these pathological proteins may be and if they are present in an individual. Here, it's another paper that is very promising. These are our Japanese colleagues from Tokyo who have done some interesting work and moving the field forward in attempting to detect this alpha-synuclein using the same assay in the blood samples. But that is going to probably take a year or two or three before we can have this assay ready. So I hope that these few examples that I have given you give you a good idea how important biofluid biomarkers and biofluid analysis is within our NAPS community. And as we try to understand the risk of developing this neurodegenerative disease in individuals who start with a sleep problem, with a REM sleep behavior disorder. And one fluid that I would really like to focus on, one biofluid, is the cerebrospinal fluid. And I just want to tell you a little bit about it. What is it? Our brain and the spinal cord actually bathe in a cerebrospinal fluid. Here you see it in a blue. It is a fluid that really encases our spinal cord and our brain. Our brain produces on a regular, constant basis this cerebrospinal fluid, which really provides an excellent opportunity for investigator to understand what is it that is happening in the brain, because everything that brain produces, right, somehow needs to be clear out of the brain, and therefore the cerebrospinal fluid contains it's in a direct contact with the brain and contains very valuable information about the function or dysfunction, if you want, when it comes to brain. And the next concept that is really tied to the story of biomarkers, biofluid and spinal fluid, etc., is the concept of a spinal tap, or we call it a little bit more in the medical term, it's a lumbar puncture of LP. And what is LP? It is a well-established medical procedure. It is actually a procedure during which we removed a small amount of the fluid from the spine in the lower back, way below the level of the spinal cord, through a small needle which is inserted in between the vertebral components here. And therefore, through that needle, we can collect a very valuable biofluid, spinal fluid, that then we can use for the analysis of either that SAA, assay, and synuclein, or other myriads of other proteins that are relevant for neurodegeneration. It's a safe procedure with very few risks. Patients sometimes may get a headache. It usually resolves with a good hydration in a short period of time. Obviously, wherever there is needle, there is a hesitation to do the procedure, but always, we do anesthetic, which is administered in this low lumbar region to minimize discomfort that may occur during the spinal tap. And we decided to tell you a little bit about it. First of all, because we focused on this novel discovery of this pathological synuclein that can be now reliably studied in the best way in the spinal tap. We talked to you about the significance of understanding that results of that assay, but in order to do that, we need to get to this valuable biofluid, spinal fluid. And we offer this to all participants in the NAPS research project, and we hope that this presentation illustrated why it is important that we have access to these biofluids, but also hopefully it shed some light on the spinal tap, for which, rightfully so, many patients feel hesitant to undergo, but which is also the only way that we can get this spinal fluid. And hopefully in the Q&A session, we can talk more about this procedure. And I will end this talk analyzing spinal fluid really allows us to study changes in the neurochemicals that are happening across the spectrum of RBD throughout all of these neurodegenerative conditions. And you can hopefully now understand how these neurochemicals in the spinal fluid can fulfill roles of many of these different biomarkers. They certainly can tell us who is at the risk of developing these neurodegenerative diseases, help with the diagnosing the condition, monitoring the progression of the disease. And now the disease-modifying trials are slowly being developed and will become available. We also hope that monitoring this pathological alpha-synuclein and other biomarkers, that monitoring of these biomarkers, we will be able to understand the potential impact of these medications and its success in slowing the disease progression. So I believe, yes, I would like to close with showing you the maps of our NAPS consortium. We are all so privileged to have an opportunity and potential to work with all of you. This is a team that works so greatly together, and we hope that you will be engaged with us. And if you are a NAPS participant, that at least this presentation and after Q&A session, you will be engaged and be willing to participate in this spinal tap. Help us do the most we can from your participation in the project for the benefit of advancing the research on RBD and slowing the disease progression. So this is all that I had to share with you today. There will be a lot of opportunities for Q&A. Again, I encourage you to submit your questions, and we already see a healthy number of questions already submitted. Now we will move to the third and the final presentation that we have for you. And we have decided today to highlight an international researcher who is a leader in the field of RBD clinical care and research, Professor Iranzo from Barcelona. The paper that I've showed you about the risk of developing neurodegenerative disease is actually done by Iranzo and his group. Dr. Iranzo is not part of the NAPS consortium, but it's certainly part of our scientific and research community and will be incoming president of the RBD study group. And I believe that Dr. Iranzo has pre-recorded his presentation because of huge time difference, zone difference, and Adrienne is going to help us share that presentation. I think it's going to be enjoyable, a very different type of presentations. So let's hear Professor Iranzo.
This is Dr. Aleksandar from Barcelona, Spain. I am neurologist and I work in the Hospital Clinic of Barcelona in Spain. I am also professor of neurology in the Faculty of Medicine. Well, I'm a neurologist and I really think that is very interesting. Sleep disorders, the sleep and how sleep is made and how the function of sleep. It's very interesting, and also the sleep disorders. Among the sleep disorders, I'm really interested in those that are related to neurological diseases, like for example, multiple sclerosis, epilepsy, and neurodegenerative diseases. And everybody knows that we have found during the last 30 years, thanks to Dr. Schenk and Howell as the first stone, that REM behavior disorder is linked to a neurodegenerative disease like Parkinson's disease, multisystem atrophy, and dementia Lewy bodies. And with my team and my mentor, Dr. Santamaria and Dr. Tolosa, we have done some kind of research and following the Dr. Mahawal and Schenk steps of the relationship between neurology, neurodegenerative disorders, and REM behavior disorder. And I think that is very interesting, the NAPS initiative here in America and Canada as well. And also that is also important involved the whole world. And this is why the International RBD Study Group, which I am the elect president, I think that is very important. I mean, people like Brad Bove, Carlos Shen, Ronald Postuma, and all of you, Michael Silver, and Donald Bly-Wise, David Wright, they're all very important people that I have followed your steps, your path, and always trying to learn from you. And for me, it's an honor to be invited to give a talk on REM behavior disorder by yourself. It's really an honor and a pleasure to be here. A pity that I cannot be in the States, but I'm here in Barcelona, which is a city that I love. Thank you very much, and thank you for giving me the opportunity to give this talk. I'm done.
All right, and then we can go ahead and segue to your presentation, so you can share your screen.
We can share the screen now and start. Okay. Share. Okay, here it is. ¿Qué es que se cae? Hello?
Yes, I see it. Looks good.
Okay. So tell me, when do I have to start?
Oh, yeah, you can go ahead and start.
Okay. So the talk of today is called REM sleep behavior disorder in visual arts and movies. And I really thank Dr. Videnovic for inviting me here. And it's a pleasure to be here with you. So as you know very well, from the clinical point of view, REM behavior disorder is characterized by nightmares and dreaming active behaviors. And it's very important to say regarding this talk that the first description in animals of REM behavior disorder was disclosed in 1965. in cats and dogs by Jouvet in France. And then 20 years later, it was first described in Neurology in humans by Schenkman, Howell, and Bundley. So this is a milestone. So if you have pets or dogs or something like this, you can see that they can display dream and acting behaviors. Of course, we don't know if they have REM behavior disorder or is sleepwalking, but there are some home videos that you can find in YouTube or even in your own dog that you can find that they have a REM behavior disorder or something that looks like. For example, this video that you can find in YouTube. So it's a dog, it's with the eyes closed, and you can see that the paws are moving, like running. And then hits the wall and wakes up. And this is very typical for REM behavior disorder. This is another movie from a friend of mine that sent me through WhatsApp this video of his dog. Also, probably a minor form of REM behavior disorder, which is the most common thing that we see in the polysomnograms in the clinical routine day. So you can see the paws, the distal movements, also the tail. And also the mouth, the whiskers. So this is something that you can see every day in your daily life. So these are Miguel and Julia, about 20 years ago or 15 years ago, I will say. He's my son, Miguel, and Julia, my daughter. And as you know, when they are very young, or at least 15 years ago, they were attached to the TV, seeing cartoons to be quiet, which was a great moment of your life as a father, as a parent, when they are quiet watching movies. And when they watch movies, they want you to be attached with them. So it's you because they want to comment with the daddy or with the mommy the movies and the plot and what's going on. So one day I was watching with Miguel Cinderella, and I saw one dog doing like RBD. I said, wow, it's nice. The next week, the movie that we saw was The Lady and the Tramp. And then there was another dog doing exactly the same RBD-like behavior. So I thought, well, you can do one single case report, you can do two cases, but let's have a review of the Disney filmography and see what's going on, if there are more examples, and then we can make a report. And so what I did is to watch that was in 2005, to watch the 46 classic Disney full-length animated films, plus more than 500 Disney short films. And that was a paper that I wrote with Carlos Schenk, and which of course the leading expert of REM behavior disorder, and Jorge Fonte, who is a leading expert of Disney films. So what we found is that there were examples of nightmares, sleepwalking, sleep-related seizure, disturbed snoring, hypersomnia, insomnia, circadian rhythm sleep disorder, and REM sleep behavior disorders. So let's focus now in Disney and RBD. So we found 4 examples in 4 different movies of RBD. In Pluto's Judgment Day, 1935, Pluto had REM behavior disorder. In Cinderella, another dog, Bruno, had REM behavior disorder. Lady and the Tramp, Trusty, another dog, REM behavior disorder. And Fox and the Hound, Chief, another dog. And you can see all these movies were released in before 1986, before Carlos Schenk and Howell Mandley described REM behavior disorder. And some of them, the first 3, even before Jouvet in Paris, in Lyon, describe REM behavior disorder in animals. So let's see those examples. But what is important of these dogs, Disney dogs, that they were all dogs, the eyes were closed, they have pierced dreams, they talk, they bark, they howl, and they whinge. They have jerking and running like movements, and then when they are awakened, they're awakened from the dream. Let's see some examples. This is Cinderella in 1951. Eyes closed.
Dreaming again. Chasing Lucifer. Catch him this time. That's bad. Suppose they heard you upstairs. You know the orders. So if you don't want to lose a nice warm bed, you better get rid of those dreams.
So that was 1951, Cinderella. But there is a Cinderella 2 movie released in 2002, and you can see that Bruno still has REM behavior disorder.
Good morning, Your Highness. Your Highness.
So it was Bruno dreaming again and doing some movements. And let's see Lady and the Tramp. It's 1955. So this is the dog, Trusty, which is an old dog, dreaming with eyes closed, sniffing.
He's dreaming. Dreaming of those bonny bygone days when he and his grandfather were tracking criminals through the swamps. They were? That was before...
Before what?
This time you knew the truth, lassie. It shouldn't have happened to a dog. But, well, Trusty has lost his sense of smell.
No.
Aye. But we must never let on that we know, lassie. 'Twould break his poor heart.
Which way did he go? Which way did he go?
Go?
Yeah, big fella. About 6'2". No, 3. Wore a striped suit, no collar.
So this is very funny. So this dog has not only RBD, but also hyposmia, which is very typical in what we see every day in our patients with REM behavior disorder. So this is the third movie, Fox and the Hound. And you will see that there are a fox and a little doggy playing. And here in the barrel, you will see a big fellow having REM behavior disorder.
Daddy, you're making that awful noise. It keeps me awake at night. Oh, don't you leave it. Take it off of me. It's windy. Gee willikers. He ever... Seriously, Copper. That's not the part you gotta worry about. Wow. Look at those teeth. That's the part you gotta worry about.
He won't get away now.
What's next? Get out, Todd. No, he's having a dream. He's chasing us.
I got him cornered. It's a big old badger.
Copper. He's chasing a badger.
No. It ain't a badger. It's a fox.
Another example is Pluto Judgment Day, which is a short, but also we can see the REM behavior disorder in some other movies, not only in Disney movies. For example, The Young Frankenstein, which is 1974, again before Howell and Schenk combined with description. It's a Mel Brooks film, and the main character is Jane Wilder. So here, the Dr. Frankenstein, Jane Wilder, is having RBD as well. You can see this. And he's a doctor, and you will see that he is also, at the end of the movie, at the end of this short movie, you will see that he is reading literature, maybe not in RBD, because that was described 10 years later.
Frankenstein. I'm a Frankenstein. Don't give me that! I don't believe in fate. I won't say it. All right, you win. You win. I give. I'll say it. I'll say it. I'll say it. Destiny! Destiny! No escaping. That's for me. Destiny! Destiny! No escaping! That's for me! Destiny! Destiny! No escaping!
Dr. Frankenstein, wake up!
What is it?
You were having a nightmare.
What's that strange music?
I have no idea.
And he was reading the Lancet, trying to know what's going on him, having these nightmares and these dreaming acting behaviors, but couldn't know because Schenk and Howell didn't describe yet REM behavior disorder. That's another example of REM behavior disorder, of dreaming acting behavior during sleep, in this classic Rock Hudson and Doris Day movie called Pillow Talk, released in 1959 in America. So we have now an example of why both Rock Hudson and Doris Day have both REM behavior disorder sharing the bed. He wakes up, and then he takes a look at Doris Day, and let's see. She's dancing in dreams. Okay, and then in another scene of this movie, Doris Day is awake, and then he's completely upset with Rock Hudson. He's very angry at him. And then pretending that he's asleep, dreaming, he slaps her. He slaps him, sorry. He's quiet. And she was telling him that he was having a nightmare, so that was an excuse to slap him. And we can move also to literature, to books, like, for example, Don Quixote, which is a classic Spanish novel published in 1605. And me, my mentor, and my grandfather, we published this paper on sleep and sleep disorders in Don Quixote. In the book, we found that Don Quixote had insomnia, Sancho, the squire, had snoring and probably sleep apnea, but Don Quixote himself also have REM behavior disorder. So, like I said, that was released in 1605. Is the typical picture of the knight, Don Quixote as a knight that he believed to be a knight, and also his squire riding a donkey. And he was demented because of reading novels and also because of a lack of sleep. These are the two causes that the author, Miguel de Cervantes, explained why Alonso Quijano, Don Quixote became demented. And in the first part of the book, in the book 1, chapter 35, there is in this chapter, Don Quixote is asleep, is dreaming, and then he's dreaming acting, and then he dreams that he's fighting against a giant, and then he gets up from the bed and have the sword and start to slash, and then he touches and stabs one thing that has inside wine, and the wine comes out from this sink, and then it looks like blood. So like Miguel Cervantes wrote, is that, and they found him, Don Quixote was found with a sword in one hand, stabbing everything as if he were fighting. And it was of note that he had his eyes closed, for he was sleeping and dreaming that he was in a battle against the giants. So this is REM behavior disorder. So one of my colleagues, Garcia Ruiz, he wrote this article, did Don Quixote have Lewy body disease, dementia with Lewy bodies? And he says probably yes, because he had demented, he had fluctuations, he had visual hallucinations like windmills, delirium, because he thought he was himself a knight, and also REM behavior disorder like we have seen right now. So could be that REM behavior is one of the clinical features of dementia with Lewy bodies. And this is a cartoon, a Spanish cartoon of Donald Duck that also had a REM behavior disorder. He's a policeman, and he's keeping safe one bank, and then the robbers came in, and then he was sleeping and dreaming that he was fighting against a cowboy that was stealing his Nancy. And then he started to shoot him in the dream, but also when in the real life, he started to shoot, and he starts to shoot and shoots the robbers. And so the robbers had to escape. So REM behavior disorder in this case was good, because he protected the bank, and the thieves were gone after they were shot. Well, we have seen examples of REM behavior disorder in movies and cartoons and books, but also there are some examples of the RBD mimics. We know that there are several conditions that they are characterized by nightmares and dreaming acting behaviors like sleepwalking, sleep-related eating syndrome, periodic limb movement disorders, and sleep-related epilepsy. And you can also find them in books and cartoons and movies. For example, if you watch these sleepwalking movies, you will, if you take a look of these Disney movies, you will see 3 examples of sleepwalking. In Pluto, in the sleepwalker short, in the Pelican and Snipe, and also in the sleep time. Donald has also not only REM behavior disorder, but also sleepwalking, according to Walt Disney. So let's take a look of this short of the Pelican and Snipe, which the Pelican has sleepwalking, an RBD mimic.
This is a story about a couple of pals who set up lighthouse keeping on top of a lighthouse near Montevideo. And by a strange coincidence, their names happen to be Monty and Video. I suppose you wonder why the little fella's keeping his eye on the big one. Well, Monty, the big pelican, is a somnambulist. You know, flies in his sleep. And somebody has to stay up and watch him in case he takes off. And little Viddy, the snipe, he's that somebody. And he watches over him with untiring devotion. If that isn't true friendship, I don't know what is. And Monty doesn't even realize it. See? What did I tell you? There he goes. Whenever Monty dreams he's a dive bomber, it's little Viddy's job to pull him out of dives. Look, imagine what would happen to Marty.
Well, as you can see in this video, in the pelican and the snipe, there's always the typical mistake that features the sleepwalkers with the eyes closed. They have the eyes open, and they also the typical mistake of stretching the hands, which is something that never happens, but is the typical thing that you can see in the movies, on cartoons, of sleepwalkers. We have another cartoon that I had when I was a child, a Spanish cartoon of Donald Duck, that also he had not only REM behavior disorder and sleepwalking, but also sleep-related eating syndrome. Here in this cartoon, he goes to bed and he gets up from the bed and goes to the kitchen and starts to eat chicken. So this is sleep-related eating syndrome. It's so a variant of the sleep walking that can also in some cases mimic REM behavior disorder. And also we have periodic limb movement disorders. It's kicking the legs that in some cases can be difficult to distinguish from REM behavior disorder. And this comes from the movie The Kid by Charles Chaplin in 1921. And you can see that both The Kid and Charles Chaplin had both periodic limb movement disorder. When they fall asleep. And even kicking the neighbor. So it's periodic limb movement disorder. And also we have one case of sleep-related epilepsy in the movie Snow White, the first Disney film. And we have the case of Dopey. As you can see, Dopey will be asleep and then starts to move and shaking and looks like a sleep-related epilepsy. Well, and like Walt Disney said, sometimes we can recognize ourselves in animals. That's what makes them so interesting. So as you can see in this talk, we have seen that there are many examples of REM behavior disorder in movies, in books, in cartoons, and so on, that they have been used as a comic element, as a funny element to enrich the book of the film or the movie. So, but you know that RBD is not funny because it is linked to an neurodegenerative disease. So thank you very much for your attention. And again, thank you very much, Alex, for inviting me to give this talk. I hope you had fun. Thank you very much.
All right,
So thank you everyone for listening to our to the presentation by Dr. Iranzo. Now, Ms. Adrian Rivera, who is our UCLA NAPS coordinator, has some additional information on our YouTube channel and other educational resources.
Hi, everybody. All right, so we are going forward. The NAPS Consortium plans to have these webinars on a quarterly basis, and all webinars will be recorded and accessible on our YouTube channel. And I provided a link in the chat, but we'll also email everybody this link as well. And all right, and then one more thing, we have our website, which is www.naps-rbd.org, where we'll be posting educational materials and videos and updates on our research as they get published. And lastly, here's our social media channels. We'll be posting updates and research findings in the realm of sleep medicine and also within the NAPS Consortium on our Facebook, Instagram, Twitter, and LinkedIn and Threads. And yeah, I will send these slides to you as well. And this webinar will be recorded and accessible on YouTube. Okay, that's all.
Great. Thank you so much, Adrian. And now it's our time, the time to move on with the questions and answer sessions. This session will be monitored by our colleague, Dr. Mike Howell from University of Minnesota. Dr. Howell is Vice Chair for Education and Academic Affairs at the University of Minnesota and is a known expert in RBD. So thanks, Mike, for making yourself available on a Sunday to help address the Q&A, and we will go ahead and hand things over to you.
Well, thanks, Alon, and thanks, Adrian, and Leah, and Jenny, and Dr. Videnovic. And I think we really want to give a big appreciation to all of those who've joined, all of those in our audience who are joining us, taking time out of your day and on the weekend to learn about REM sleep behavior disorder. We realize that a large number of you are in the research study, as well as other research studies we have going on. I don't think we can convey our appreciation enough, because none of this would happen if it wasn't for yourselves volunteering your time, as well as bed partners, family members also contributing. We really, really greatly appreciate it. The purpose of the NAPS study is to develop insight and wisdom on how REM sleep behavior disorder is associated with other neurological diseases, as we've been talking about for the last hour. And this means that we can't do it without patients such as yourself. And we really, one of the great joys, I know my colleagues would agree with this, one of the great joys of being involved in NAPS is it does give us clinicians an incredible opportunity to get to know you and your families. The sessions we have go on much longer than a typical clinic visit. And I just want to share my great appreciation for all of the research subjects that I personally worked with, but also all of those that you've worked with my colleagues. In addition to that, great appreciation to all of our coordinators, research coordinators, and administrative folks who've helped make this happen. So we'll go ahead and start tackling the questions that have come up. A couple big themes. I'll just try to answer a couple of these right off the bat. We did get a few.
Mike, sorry if I may interrupt, and sorry for this interruption. I see that we have 31 questions posted in the Q&A chat. We have about 40 minutes left in this webinar. It would be really awesome if we can address majority of these questions. So let's really try to focus, all three of us who are on the panel, to give these answers within a minute and a half maximum, so that we can really accommodate most of the questions. What do panelists think about this?
Agree. One of the things I was just going to do, Alex, I was just going to tackle, some of them are very, some of them are very, hang on, some of them are very, very similar, and I was going to knock a few out right away. One of which is, we've had a couple specific questions regarding getting set up for clinical care. Per our IRB, we cannot do, our apologies that we're not addressing those. Please just reach out directly to individual sites, and they will coordinate that care through your clinic. That will be great. So let me just go ahead and jump in right away here. So a couple of questions that came in before the Q&A. Here's one question. This has to do with melatonin and its effect on the sleep study results. And we've had a few questions related to this, and so we'll try to tackle all of those. But the question specifically had to do is, I take melatonin and I haven't had a sleep study yet. I probably have REM sleep behavior disorder. Is there a worry that taking melatonin would falsely normalize my sleep study? This is something that we do wrestle with and try to come up with a balance. Certainly individuals who are having very dangerous dream enactment behavior, which as many of you know, can happen. We try to be as careful with this as possible. Melatonin appears to have a beneficial effect on REM motor tone, so the abnormality we usually see on the sleep study. It is normalized for a good 1 to 2 weeks after someone's been on melatonin for a prolonged period of time. So if you stop it tonight, you may very well still have basically a normal sleep study for a few days. So we do our best to try to get people off of these treatments for the melatonin anyway, for a little while. But sometimes that's challenging. Sometimes we try to get them off for a week. Sometimes we try to get them off for 2 weeks. Sometimes we don't have that much time because the scheduling of the sleep study or the behaviors themselves are really quite dramatic or dangerous, and so we minimize that. I think I can speak for most of my colleagues, though, that even if the melatonin improves the REM motor activity on the sleep study, usually we're still able to identify the condition. It's often, it doesn't make it completely normal. Usually we're able to normalize that. We got a couple questions also. Same idea with clonazepam. Clonazepam is a little different. Clonazepam, as far as we can tell, does not normalize the PSG. So for those patients who need to be on clonazepam, they can stay on the clonazepam. They can take clonazepam the night of their study. A couple other questions that have come along in terms of, okay, I've done melatonin, I've done clonazepam, what else is there? And I can, Dr. Alon Avidan and I recently finished up a task force where we specifically tried to address that. Alon, would you mind just trying to tackle that one a little bit, of someone who has been on clonazepam and been on melatonin and just kind of thinking of something else?
Sure. Oh. So for the last, I don't know, Mike, how long it's been, maybe 5 or 6 years that it took us to come up with the some of the recommendations that have been published in the new RBD study guidelines. But the task force that was enlisted to generate those evidence-based evaluation of management decided that the best way to really address treatment is by focusing on the phenotype of RBD, whether it's there are patients with isolated RBD, secondary RBD, which are those patients who have already phenoconverted to a neurodegenerative condition, as well as drug-induced RBD. Now, once you have established once you came up with a decision of whether or not the patient fits one of these categories, then the next task was to really evaluate the ample of literature that became available in the last 10 years. And our data demonstrated that for folks with isolated or formerly known as idiopathic RBD, that data supported the use of clonazepam, melatonin, pramipixole, and rivastigmine. For secondary RBD, those are individuals who have phenoconverted with a neurodegenerative condition, a neurologic condition. Treatment would support the use of clonazepam, melatonin, and rivastigmine, but not support the use of deep brain stimulation. For folks who have drug-induced RBD, that is a patient who has been placed on a serotonergic antidepressant, particularly an SSRI and SNRI, the recommendation would be to proceed with drug discontinuation, or potentially put the patient on another antidepressant that doesn't have a serotonergic property, like a bupropion, also known as Wellbutrin. So just to give you a summary, this is where all the recommendations are listed based on the objectively verifiable indicator on what research we have used in reducing the dream enactment frequency, the RBDQ score, and the RBD frequency. Not to get too hung up in the details, we also recommend that every patient should be addressed with safety interventions, padding the bed, removing sharp objects, and optimizing a safe and a comfortable bedroom environment to prevent patients from becoming injured during the episodes. Everyone also used, besides the task force recommendations, also drugs that we have found on our own clinical experience. For example, I like the use of melatonin all the time, but I also like the use of time-release melatonin. The task force did not have enough studies to really recommend between immediate release and sustained release melatonin, but given that there weren't enough clinical trials on the sustained release melatonin, we couldn't really provide enough of a strong recommendation just because the literature was not present. But I do, and I know my other colleagues probably support the use of sustained or time-release melatonin because it does last a little bit longer and potentially has the efficacy to address dream enactment behavior later at night. Turn this back to you,
Great.
Mike.
Thank you, Alon. We had several additional questions in regards to the lumbar puncture. Certainly doing a lumbar puncture, as was discussed earlier, this is a procedure. It's a safe procedure, but it can be an uncomfortable one. So again, we can't thank you enough for going through all of this. And of course, some individuals are just not able to do a lumbar puncture, and we understand that as well. In terms of why, and I think that was nicely kind of addressed earlier, but this is the way that we can get the best possible look at the cerebral spinal fluid, short of doing a brain biopsy. And we're not going to do a brain biopsy in this study. One question that came in is like, well, since it looks like you can also identify this synuclein pathology in skin and in tears and in salivary glands, what about doing that instead of the lumbar puncture? And I think the short answer is we may very well be getting to that, but in terms of where the evidence is right now, the best chance we have to identify that synuclein pathology is with a CSF evaluation through a lumbar puncture. Lots of questions regarding phenoconversion, and because I think this is probably if I had to guess, what's on most people's minds. And the reason why you're participating in this, of course, is the relationship between REM sleep behavior disorder and neurodegenerative disease. And oftentimes, I'm sure Dr. Videnovic and Dr. Avidan would agree on how many patients understandably read a lot of literature and then try to calculate backwards. Well, I've had RBD for so long, and does that mean I'm probably going to develop Parkinson's disease or something similar to it in the next 2 years or 5 years or 10 years? And the short answer is that we only have very general understanding. We can help a lot of people understand their risk based on other things, and this is what a lot of what we're doing in NAPS is how important is smell, how important is constipation, how important is difficulty with blood pressure control, and if many of those things are otherwise doing reasonably well, and you're still functioning really quite well and not having motor symptoms, and your balance is good, the likelihood of an imminent conversion to a neurodegenerative disease is really quite low. And other things that we're trying to understand with NAPS and other studies is what is the relationship between antidepressant use. Antidepressant use, in particular SSRIs, has really thrown us because SSRIs can notoriously cause dream enactment, including in individuals who are very young adults. And the question is what does that mean? Are they at higher risk for? Are they at risk for neurodegenerative disease? Well, they're certainly at lower risk than people with isolated REM sleep behavior disorder, but do we know if they're at no risk? We just don't know that at this time. We had several questions in regards. I'm sorry. The one more point I wanted to bring up, and I really appreciated one of our One of our leaders of this study, Dr. Ron Postuma from McGill, has made points at a couple recent meetings that it's been his experience, as it's been mine, and I think it's been a lot of other individuals' experience, that this what we've been citing of 5 years or 10 years or 12 years or 15 years keeps getting longer and longer and longer and longer. And that's good, right? That's a good sign that people's brain function continues well longer and longer in general, in large part because we have a better understanding of this condition. We are picking up people much earlier. I think, as you can imagine, if it was 20, 30 years ago and you would have gone to your doctor with dream enactment, or if you would have looked up dream enactment, you may very well not have seen anything. You would not have been informed about the symptoms, that it's a real phenomenon. So early people were diagnosed with more severe condition, and thus, not surprisingly, they were more likely to progress to Parkinson's disease or something like it very soon. And now, as we're talking to each other, many of you who have dream enactment in relative isolation are really doing incredibly well. And then we would also point out that especially Parkinson's disease is a treatable condition. I mean, we've been treating Parkinson's disease with a variety of different medications and surgical therapies for decades now. A couple questions on the structure of NAPS and its relationship to the Michael J. Fox Foundation. So NAPS is the North American Prodromal Synucleinopathy study. It is funded by the National Institutes of Health. It is an international study involving our colleagues in Canada, but we also have collaborators across the world, including Dr. Iranzo from Barcelona and Dr. Hu from Oxford, and many others. The Michael J. Fox Foundation is obviously very interested in REM sleep behavior disorder and have funded the PPMI initiative to standardize data collection for clinical trials. And many of us have funding both through the Michael J. Fox Foundation and the National Institutes of Health. All three of us on this call are neurologists. All three physicians on this call are neurologists and sleep specialists. As a general rule, most funding through the Michael J. Fox Foundation are neurologists who are movement disorder specialists, just as a general rule. But the question was, do we collaborate? Yes, we very much do. A few questions in regards to what about results? Obviously, the point of these projects are to advance the science forward so that we can help develop a cure for Parkinson's disease and dementia with Lewy bodies for everyone, and not necessarily for each individual person. Although, we would love for all of our participants to, do better because of what we're discovering in the NAPS study. We do share, and we are obligated to share clinic, and we do, and I can tell you, we do it readily and enthusiastically. If any clinically significant result, whether or not that's a finding on an MRI scan, or positive skin biopsy test, or whatever it might be, we do share these findings with the patients themselves. A lot of the data is research, though. It is sometimes we get findings back that we just honestly, at this point, we just don't know what they mean. And that is where you come in to kind of help us follow this over time prospectively. But we do our best to, we certainly share the clinically important information, but also share other information as it comes along.
Mike, can I just make a comment about disclosure? And I think that's a really important point to maybe sideline into the fact that disclosure may be welcomed or it may be unwelcome. So before we as clinicians, we want to be sure that we're not overwhelming patients with information that they may not want to hear. So even before the disclosure of a diagnosis of RBD and its implications, I generally ask patients what they wish to hear about the condition. I think that's important because I've had some patients who were not terribly happy to hear that there may be a risk of a neurologic condition down the road. And I think this may be echoed by some of you as well. So I may ask the question, well, we made a diagnosis of REM-sleep behavior disorder, and there is a potential that this diagnosis may be associated with another condition, another neurologic condition. And would you like me to go further and let you know more about this condition and its implications? And sometimes the answer is definitely, I absolutely want to know everything possible. And that's certainly the majority of patients would probably choose that route. But there are some patients who told me straight no. I'm glad you asked me that, because I do want to be able to think about this and make a decision after I have a little bit more thoughts about what I want to hear about the condition, rather than being told everything. And perhaps those are patients who may feel a bit anxious and they want to wait and make a decision later on as more information becomes available. But you're right. For the vast majority of patients where there is a need and an expectation that we share data, we share the phenoconversion rates, that I think it's important to then be able to, when we have enough information that's validated and where we have data that is available on what is the implication of having a positive test, or a positive if you have a more frequent muscle augmentation on the muscle tone during the sleep study, does not have any implication. So I agree with you on that completely, Mike, but it tends to be a fairly important decision about what people want to hear, and being able to take that into the decision of what and when to share and how much to share.
Another question came in on, is there any documented cases of spontaneous remissions of patients with REM sleep behavior disorder? I think it's worthwhile to point out that isolated dream enactment in the setting of sleep deprivation or stress, or in particular medications, is actually really quite common. I mean, there's numerous examples of most dorm room floors have some examples of kind of bizarre behaviors. A lot of it is sleepwalking. Some of it often sounds like dream enactment. Individuals will describe dream enactment. Sometimes you may have a bed partner who may act out their dreams occasionally and rarely and intermittently, but then actually are perfectly normal on their sleep study, and it never really happens again except in a setting of sleep deprivation or maybe a little bit of alcohol withdrawal. So that it is. So the answer is yes. There is numerous examples of people who have isolated dream enactment who never persist into what we'd probably call a consistent diagnosis of REM sleep behavior disorder, and are not and don't appear to have an underlying neurodegenerative condition.
I'll expand on that a little bit. We know that even within the diagnosis of RBD, there are patients who are in repetitive testing, when we do this objective testing of motor and cognitive function, fluctuate. And they improve for certain period of time, and then they go back, etc. We are considering calling these individual patients wobblers. And we are actually planning to conduct an investigation and a research project in which we're going to try to understand these patients with fully diagnosed REM sleep behavior disorder who fluctuate in time, and how do they behave over long term in terms of their risk for neurodegenerative disease. So as Mike said, yes. So the answer is yes, both for those mimickers, but also for patients who have fully blown and confirmed REM sleep behavior disorder.
Thanks, Alex. That's great. Some questions of if the lumbar puncture and the skin biopsy come back and they're negative, what does that mean? Does that mean They not only do they not have the pathology, but they're never going to get the pathology. Will they develop it slowly over time? If there is a little bit, will that progressively get worse? The short answer is we don't know. We could take guesses, and I think most of us would probably guess that this is a progressive process. So somebody who doesn't have it now, that's great, but it's still quite possible 5 years or 10 years or 20 years later, they may develop it. But the short answer is we don't know, and we're never going to be able to understand that without all of you. So we, again, huge thank you for all of your participation.
I will add to this as well. We have introduced this really. When you hear this presentation, you think that this is a very powerful essay, right? But we really want to reiterate to you, this essay is in the early stages of the development. Essays done and results from the lab to lab vary and can give a variable results. The fact that someone is positive, we really need to develop much more robust pipeline of these essays and understand whether we can quantify that finding of the pathological protein in order to know what that means. So we wanted to share these exciting news with our community. That certainly includes you as a very important and the key people in our community. But we just want to tell you that these are early stages of a very promising development, and we all need to see how is this going to develop further.
Several questions about anticipating disease-modifying drug trials. I mean, that's the whole point. When are we going to start working on developing a cure? I can tell you we are actively talking about this. If we had an ideal candidate agent, we would already be doing it. This is an expectation from the National Institutes of Health. This is a greater than $30 million study, and the expectation is that we initiate disease-modifying trials. We've had conversations regarding exercise. We know that anaerobic exercise appears to help prevent to preserve brain cell function among individuals with early onset Parkinson's disease. So the thought is, well, why don't we do that with REM sleep behavior disorder? There's been questions about everything from medications such as or supplements such as melatonin, coenzyme Q10. What about augmenting slow wave sleep with oxybate therapies? All of these are conversations, and there's no clear, obvious, appropriate one right at this moment. But I can one of the questions is how soon. So let me just throw a number out there. I would guess we will have a clinical trial going by 2026. I'll just throw that out there, and then you can hold me to that. But that's certainly a goal that we should start. We should put a flag down and a marker down if we need to start very soon. And part of that is we cannot do it until we get a good, strong baseline of individuals, which we have now done. I think at the end of 2023, I think we can say that of the NAPS study. And my apologies, I can't remember exactly what our number are up to right now, but it's just fantastic because of all of you. There is a question about this, getting back to someone who can't tolerate melatonin and clonazepam. There was a specific comment on this individual has symptoms of cognitive impairment, and based upon the task force that Alon and I were on, probably the recommendation there in that case would be rivastigmine or donepezil, I think is probably where most of us would probably suggest. But again, please don't take this as particular medical advice. Make sure you talk it over with whoever is taking care of you or a family member. All right, I'm just looking for lots of.
In the meantime, while you look through, I just would like to inform everyone that this webinar will be posted on the website, so you will be able to listen and view these webinars and share it to friends and caregivers and family members who are interested in that. And we will also try to answer questions that have not been answered during this live Q&A session.
There is a question here that I have kind of wondered about myself. The question is, and this was referred to in the Alex Iranzo presentation on does an individual's eyes need to be closed to have REM sleep behavior disorder? I think the answer to that is no. They don't have to be closed. I think on sleep studies the eyes are often closed, but actually let me just put Dr. Avidan and Dr. Videnovic on the spot. How important do you think whether or not the eyes are open or closed is in terms of the diagnosis?
In my opinion, and experience, they are almost always closed.
Mm-hmm. Alon?
Yeah, the eyes are closed. What we've seen, though, in the sleep study is very interesting. When a patient describes a dream enactment episode, we can actually track the eye movements to where the patient may have visualized the dream enactment or where they have had an image, for example, of an intruder running after them, or the patient trying to defend themselves against a supposed image or imagery of another intruder or another person. And the patient will tell the technicians, the sleep technicians, that they were moving from the right side to the left side of the room and tracking an animal or an intruder. And at the same time, we can actually track and see where the eye movements are of the patient during the sleep study, where the eyes are moving, and whether the eyes are closed or open. The ability to track and see that the patient is actually describing and moving their eyes according to their own subjective description is very much in alignment. So that tells us that the brain, the imagery is real, and the patient are interacting with a disturbing imagery or an intruder. The eyes, as Alex said, the eyes tend to be closed. They're more likely to be open during a non-REM parasomnia or a disorder of arousal, but in RBD they're generally closed. They do become towards the end of the episode, I think that some patients may open their eyes as they begin to interact with the environment, particularly if a technician is asking them to describe what had happened.
Another question, kind of asking to expand a little bit on the importance and significance of antidepressant-associated REM sleep behavior disorder. As a general rule, REM sleep behavior disorder in isolation, meaning not affiliated with a SSRI and antidepressant, not affiliated with narcolepsy or a clear neurologic condition. In those circumstances, the individuals with isolated RBD tend to be older, a little older, 50s, 60s, usually when it presents, tend to be more likely men, but certainly women get REM sleep behavior disorder, and there's very good reason to think that REM sleep behavior disorder is underdiagnosed in women. In fact, we know that. SSRI, antidepressant-associated REM sleep behavior disorder, is more likely to occur in somewhat younger individuals, often in their 30s and 40s, much more likely to be in women, and we need to understand a lot more about it. And we are, if you have, if you had been on an antidepressant medication such as Zoloft or Prozac, and relatively soon thereafter developed clear dream enactment, that you are absolutely eligible to enroll into NAPS. And to give just a little plug out, we also at Minnesota, we have a new NIH study specifically focused on that, so you can reach out to me as well specifically. But we still take the condition very seriously. It is we recognize that people can still have potential injuries to themselves or bed partners. It's often very embarrassing, and we would like to help you with that. Comment about this often comes up. Let me pitch this over to you, Alon. So melatonin, melatonin is in the United States is an over-the-counter supplement. How do you manage that? Do you give prescription melatonin? How do you deal with dose? Do you have a particular favorite? How do you deal with melatonin, Alon?
Yeah, so melatonin, as Mike said, is not regulated by the FDA here in the U.S. It is more regulated in Europe, in the EU, in Canada. You do need a prescription, which is probably easier because it is, even though it may be more expensive, you do have a standard dose that you can actually trust. Here in the U.S., it's actually fairly variable. If you pick a melatonin bottle and you see that it has a certain milligrams of melatonin in it, data actually shows that the company, the manufacturer, doesn't have to necessarily have the exact specific dose of melatonin in it. And in fact, some manufacturers will mix in other substances, which is particularly important in pediatrics because some of the gummy melatonin has recently been shown to have a THC, which is obviously a big safety concern. But for all practical purposes, and to answer Mike's questions more specifically, I do have a few examples with brands that I would like to just highlight. I don't have any affiliations with those brands or any stocks or any other conflicts. I do want to mention that this is merely based on patients' experience. So one of the brands is called REM Fresh. It's available through Amazon. There was a little bit of a hiatus in the manufacturing of this brand. It comes in 1, 5, and 10 milligrams. The 5 milligram time release seems to be fairly well tolerated. It's a little bit more expensive, but it does seem to offer patients who have used the more traditional brands that they just pick off the shelf. That particular brand does seem to offer a little bit more efficacy just based on my own limited observation and seeing patients and what they report back. Another brand is a 6 milligram time release melatonin from CVS. That's a little bit cheaper and probably works just as well. What I would really try to avoid is the immediate dissolved melatonin or the sublingual melatonin or melatonin that is coupled and given with other substances like diphenylhydramine or in combination with other sleep aids, because that may have an undesirable side effects in making patients a little bit more groggy. Here, the melatonin is not used to induce sleep. It's really used to or uncouple the dream enactment with the exhibition of the elevation in muscle tone and designed to prevent the augmentation, the abnormal augmentation and elevation of muscle tone. But those are the two brands, CVS and REM Fresh. You know, Mike and Alex, you probably have some experience with other manufacturers, but that's my own experience.
That's as good as I can offer, Alon. Another follow-up question on the SSRI was associated RBD. As someone who was on an SSRI, dream enactment emerged. They went off the SSRI, but the dream enactment persisted. And the only thing I can say about that is that happens a lot, and we don't understand a lot about it. My approach is if the SSRI or the antidepressant medication is really helpful for an individual's mental health, whether or not it's depression or OCD or anxiety, I want you to stay on it, or I want you to be on something that's giving an equal, if not better, efficacy of that mental health challenge. So I mean, this is often a tricky situation because frequently these medications are really, really helpful for individuals. Let's see here. Alon, Alex, as you've been kind of scanning through and the questions, anything else that we haven't talked about? Alon, let me put you on the spot here. We got one question. This always comes up about cannabinoid agents and cannabis and THC. Alon, I'm going to put you on the spot for that one. But Alex, did you have something before that?
Yes, one question caught my attention, and it's really important. One of our attendees suggested that we should include participants and patients in designing studies. This is exactly what we plan to do. And within the recruitment, education, and outreach core, we will be creating a patient advisory council that will inform broader decisions that are relevant, not only designing the studies, but how do we reach out to general public, communities, etc. And that is between the education committee and the recruitment, retention, and diversity committee, very important mission. So there will be more to come about that. Just want to make sure that everyone is assured we are thinking about it. So Alon, back to you.
Yeah, and the question was about cannabis and cannabinoids. Well, not to get too much into the weeds, I would like to say that I've seen it go both ways. I've seen some patients who took cannabis and had more worsening of their dream enactment, whereas other patients who also had a little bit more insomnia, a little bit more RLS, more pain, say that it had some moderate efficacy. So at this point, we don't know, but certainly if patients are willing to try and under the observation and the oversight and supervision of their primary physician, I think it's probably something that is up to the patients, and certainly they're welcome to experiment and see if that seems to be effective. We just don't have data, and we cannot make a recommendation for or against at this point.
Couple quick things to address before we say goodbye, and thank you for everyone who sent in questions, and our apologies for not getting to all of them. It's a couple questions in regards to the relationship between REM sleep behavior disorder and post-traumatic stress disorder, trauma-associated stress disorder, and TBI's brain injury. Yes, there is very much a relationship. There are numerous individuals who have, whether or not it's PTSD, trauma-associated sleep disorder, TBI, and then subsequently develop dream enactment, or the dream enactment occurs at about the same time. It does appear to be a subtype. We don't know its relationship with neurodegenerative disease. It may very well be separate. We don't know. This is again one of the the questions that NAPS is looking to help answer. And then finally, just in an excellent question on, well, what can we do, since conventional medicine has not given us an option for disease-modifying therapies, neuroprotection. I can tell you what I tell my patients, which is with the best evidence we have is aerobic exercise. So the kind of exercise where you sweat. So if you can sweat for 30 minutes 3 times a week, that's a great place to start. And that in addition to possibly helping protect your brain, we also know all the other numerous benefits that you get from exercise. And on the other days of the week, try to mix in there some weight training, because that'll help with bone health, which all of us could benefit from, especially as we get older. But it's now in Minnesota, it's now 1:01 p.m. So I'm going to go ahead and shut it down. Let me go ahead and say thank you to everyone who joined. Any final thoughts, Dr. Videnovic and Dr. Avidan?
Yeah, we would like to thank our patients. Really, without your participation, this work would not be as meaningful. We really need, we're really approaching this trial and our collaborative work with your inputs. You help us know how to navigate through what's important, what's of highest quality, and highest what is of most value for you at this point, because this research cannot occur in a vacuum. So we really entrust and value your feedback, your questions, and everything that was said so far and was raised in the chat. We will look at this more carefully and try to do our best to really move forward, keeping and echoing those comments in sight moving forward.
And I will join in echoing these comments by Drs. Howell and Avidan. Thank you so much for joining us. Hopefully we will remain more engaged in coming months. Again, we will plan these webinars to happen on a quarterly basis. We are very much appreciative of you joining today, of our AV team, specifically Brian, who managed this webinar really seamlessly, and also to Adrienne, Leah, and Jenny McClellan from the NAPS Consortium for keeping us organized and moving these initiatives forward. Have a great rest of the Sunday. Thank you, Alon. Thank you, Mike. And we continue our important mission. Thank you. Bye-bye.
Thanks, everyone.